This is Farah Rahman. I'm an infectious disease fellow at Icahn School of Medicine at Mount Sinai in New York City. And today I'm going to be talking to you about HIV and specifically epidemiology and the natural history. So first, with the epidemiology. So to begin, HIV remains a significant global health concern despite being a treatable disease. Many persons living with HIV are not aware of their status because they haven't been tested or they haven't been diagnosed and are not receiving care. Those with undiagnosed or untreated infection are responsible for most new infections, as you can imagine. Diagnosis and successful treatment are crucial for both personal and public health. So HIV transmission occurs through sexual contact or exposure to other body fluids. Reducing transmission can be accomplished by using barrier methods, such as condoms during sexual contact, or through clean syringes, needles, for those that are IV drug users. Universal blood donor testing has all but eliminated infection through blood transfusion, at least in the United States, with the current risk estimated to be in 1 in 2 million, and that is blood transfusions done in the United States. So this is risk of HIV-1 transmission per single exposure, and this is the percentage risk in the United States. So occupational, so that is a needle stick, is 0.23%. Occupational through mucous membrane, so splashing of body fluids, that's 0.09%. Needle sharing, so that's needle sharing in injection drug users, is 0.63%. Receptive anal intercourse is 1.4%. And receptive vaginal intercourse is 0.08%. Insertive anal intercourse is 0.11%, and insertive vaginal intercourse is 0.04%. So in regards to treatment with epidemiology, so HIV treatment has potential to reduce new infections, and in addition to benefiting the treated person. So successful treatment is associated with significant reductions in HIV transmission, as you can imagine. And although reducing the viral load, and the viral load is a lab test that we get on HIV patients. So although reducing the viral load to an undetectable level in the blood does not say that it's absent in the semen or vaginal fluid, the rate of transmission from a sexual partner with undetectable blood viral load has demonstrated to be close to zero. So I'll explain that further. So there is this saying that an organization in the United States, the Centers for Disease Control, or the CDC, the slogan that they coined, U equals U, which means undetectable equals untransmissible. So what they said, this was back in September 2017, that effectively no risk was with when a patient is deemed undetectable, meaning their viral load cannot be seen through the lab, they're untransmissible. So U equals U. The risk is extremely low to transmit that virus if that patient is undetectable. There is something that we like to hone in on called the treatment cascade. So these are steps of medical care necessary to achieve successful viral suppression that consist of testing and diagnosing infected persons, linking those patients to care and counseling and treatment. And then even though we link them to treatment, what's important is to keep them in treatment. So keeping them in a treatment program and making sure that they're taking their medication, their antiretroviral medication, and other treatment adherence. So each step along the continuum of care is a potential obstacle to successful management of HIV on both a personal and a public health level. So even in high-income countries in the United States, we do have poor rates of retention and care and adherence to medication. So there's actually one study that showed that undiagnosed and patients that are not in care with HIV were responsible for 91.5% of the HIV transmissions in the United States. And this was a study back in 2009. So basically, this is just reiterating the importance of keeping patients that have been diagnosed with HIV in the care. So just to touch base on HIV in Pakistan, this is from statistics from UNAIDS. Statistics from 2018 is the latest statistics we have. So in this information that they posted, so 160,000 people were living with HIV in Pakistan. The HIV incidence, so incidence meaning the number of new HIV infections among the uninfected population over 1 year. So the HIV incidence per 1,000 uninfected people of all ages was 0.11%. The HIV prevalence, so percentage of people living with HIV currently among adults ages 15 to 49 years was 0.1%. 22,000 people were newly affected with HIV in 2018 in Pakistan. 6,400 people died from an AIDS-related illness. And there had been a 369% increase in the number of AIDS-related deaths since 2010. And that was from 1,400 deaths to 6,400 deaths. So the number of new infections in Pakistan has also risen from 14,000 to 22,000 in that same time period. And that in 2018, 14% of people living with HIV knew their status, 10% were on treatment, and of all adults aged 15 years and over living with HIV, 10% were on treatment. 11% of children ages 0 to 14 years living with HIV were on treatment. 10% of pregnant women living with HIV accessed antiviral medication to prevent transmission of the virus to their baby. And then early infant diagnosis, so the percentage of HIV-exposed infants tested for HIV before 8 weeks of age was at 2% in 2018. And of the 160,000 adults living with HIV, as I first mentioned, 48,000, about 30%, were women. And so new infections among young women were less than among young men, but treatment was lower among women than men. So 7% of women living with HIV were on treatment compared to 11% of adult men in Pakistan. And only about 44% of women and men that are ages 15 to 24 years old correctly identify ways of preventing sexual transmission of HIV. So that's, barrier methods, for example. So this is just to say that, this is an entity, a disease entity that you should know about because it is there in Pakistan. So I'm going to touch base on prevention before I go to the natural history part of the talk. So I'm going to talk about post-exposure prophylaxis, which is called PEP, PEP, and pre-exposure prophylaxis, what we call PrEP, PrEP. So I'll first start off with PEP. So this is post-exposure prophylaxis. So this is medication that you would give after an exposure of a person. So therapy for uninfected persons to prevent the infection after exposure, whether that be an occupational exposure such as a needle stick or a non-occupational exposure such as a high-risk sexual activity. And the prophylactic medication, which is the 3 drugs, which I will go over. So the prophylaxis medication should be started as soon as possible after the exposure. The sooner the better. And it is not recommended to start more than 72 hours if more than 72 hours have passed. So there's 3 drugs that are involved in post-exposure prophylaxis, or PEP. So these names are a little confusing, and I'm sure they're new to you. And in a later lecture, I'll go over some of those antiretroviral medications, but I just want these in your mind for now. So it's a 3-drug regimen that you give for 28 days, so 4 weeks. And the 3 medications, the first one is tenofovir, the second one is called emtricitabine, and the third one you can either use raltegravir or dolutegravir. But it is important to use all 3 medication for post-exposure prophylaxis. And also HIV testing for the exposed person is also very important. So you want to test the patient at the initial visit, so at the baseline visit, and then at 4 to 6 weeks later after the exposure, and at 3 months after the exposure. So very important to make sure that they get HIV testing after a high-risk exposure. So again, this is post-exposure prophylaxis. When a person has had a high-risk exposure to HIV, you want to give them this 3-drug regimen, and you want to do it within 72 hours of the exposure. Then there's something called pre-exposure prophylaxis. So PrEP, P-R-E-P. So this is medication that is indicated for select people at high-risk exposure to HIV to reduce the risk of infection. And unlike PEP, post-exposure prophylaxis, which is 3 drugs, PrEP, pre-exposure prophylaxis, is 2 drugs. So it's the same 2 drugs that are involved in PEP. So it's still tenofovir and emtricitabine. It comes in 1 pill, but it's a 2-drug combination. And you take it once a day. The patient would take it once a day. And like I mentioned, it's for specific groups of persons that are at high risk for HIV, including men who have sex with men, we call MSM, persons at high risk through heterosexual contact, or patients that have IV drug use. These patients should also continue to be counseled on barrier precautions, so condom use, on medication toxicity, and on continued risk for other sexually transmitted infection, STIs, such as gonorrhea and chlamydia. And for these patients that you prescribe for PrEP, testing should be performed for HIV, hepatitis B, kidney function, and pregnancy before you start them on PrEP. And then you want to monitor for HIV, STIs, and pregnancy every 3 months, and continue to monitor their kidney function every 6 months. And the reason we want to monitor their kidney function is the tenofovir. The tenofovir can cause kidney injury. So it's something that we do want to keep a close eye on when patients are on PrEP or pre-exposure prophylaxis. So again, PEP is 3 drugs. PEP is post-exposure. PrEP is pre-exposure, and it's 2 drugs. Okay, so I'm going to go to the second part of the talk, which is the natural history of HIV. So just an introduction, HIV is a retrovirus. It infects CD4 lymphocytes, among other cell types. There's a depletion of the CD4 T helper cells, and it results in impairment of cell-mediated immunity and increasing risk for opportunistic infections. So opportunistic infections are infections related to the HIV infection, and I'll go over opportunistic infections in a later lecture. But I just want you to be aware that there is this increased risk for infection for HIV patients. And there's 2 types of HIV, easily labeled as HIV-1 and HIV-2. HIV-2 primarily occurs in parts of Africa, and it's pretty rare in the United States. And interestingly enough, HIV-2 is generally less progressive than HIV-1. It's less immunocompromising, so there's lower risk of opportunistic infections in HIV-2 compared to HIV-1. So something just to be aware of, the differences between HIV-1 and HIV-2. So some virology review with HIV. So I have a little graphic after this, so I don't want you to get bogged down or intimidated by all this virology language. I'll go over it in the next slide as well. So HIV, it's an enveloped virus. It's a single-stranded positive sense RNA retrovirus. And there's 3 different genes that I want you to be aware of, and that could come in your examinations. So the E and B gene, so this leads to production of GP160. And GP160 is cleaved to produce GP120 and GP41. And these are important. GP120 and GP41 are the ones that I want you to be more aware of. So GP120 attaches to the patient's CD4 T cells, and GP41 leads to fusion and entry into the immune cell. And so I'll go over that in the next slide with the picture. Then there's the GAG gene, the GAG gene, leads to the production of P24 and P17. P24 is something to definitely be aware of. It's the viral capsid. P17 is the viral matrix proteins. And then the last gene is the POL gene, POL gene, leads to the production of 3 different enzymes. So the reverse transcriptase, the aspartate protease, and the integrase. So here's the picture, and so just ones that I want you to be aware of right now. So the GP120, like I mentioned, it comes from the ENB gene, the N gene, and it's the docking glycoprotein. So like I said, the GP120 is how it attaches to the patient's CD4 cell. So you can see how it kind of just grabs on. GP41, that's the transmembrane glycoprotein, and like I mentioned, GP41 leads to the fusion and entry into the immune cells. And then the other ones here, you can see the capsid protein P24, and then the matrix protein P17. So those are the big ones that I want you to be aware of. So to just quickly review the pathogenesis, so the HIV attaches to the surface of the hosts, the humans, CD4 T cells, and it does a co-receptor binding to either, there's two different types, so the CXCR4 or the CCR5. Again, this is a very just kind of nuanced a little bit. I just kind of want you to be aware of this language and be aware that there are 2 different types of co-receptor binding. So the CXCR4 and the CCR5. Okay, so the HIV enters the cell, uncoats, and its RNA is reverse transcribed by the reverse transcriptase. So that's that enzyme that the POL gene makes into DNA, which integrates into the host genome and creates billions of viral particles, lysing the host cells and releasing the viral particles into the bloodstream, infecting other CD4 T cells. Excuse me. So then to go on for the stages of HIV, so first is the viral transmission. So like I mentioned before, HIV is a bloodborne virus transmitted by sexual intercourse, sharing needles, or vertical transmission from mother to fetus. The second stage is the acute HIV infected stage. So this is also called primary HIV infection or acute seroconversion syndrome. And then last is the chronic HIV infection, and that's actually further subdivided into a few different stages. So first is chronic infection without AIDS. And then you have AIDS, which is characterized by a CD4 count less than 200 or the presence of any AIDS-defying condition. And then the third is advanced HIV infection. So that's characterized by a CD4 less than 50. So a CD4 is a lab test that we get on all our HIV patients and basically how they're doing and how their virus is responding to their medication or lack thereof. So AIDS, basically, when somebody says AIDS, what they mean is that their CD4 count is less than 200. And that advanced AIDS, advanced HIV, is when that CD4 count is less than 50. And then like in the second, number 2 of the chronic HIV infection, so AIDS with CD4 count less than 200, or the presence of any AIDS-defining conditions. So those are specific, like Kaposi sarcoma, pneumocystis pneumonia. Again, I'll go over those in a later lecture, but there's a list of infections that are related to, that are called AIDS-defining conditions, and I will go over that in a later lecture. So viral transmission, so the first stage, so it's an HIV infection, like I mentioned before, usually acquired through sexual intercourse, exposure to infected blood, or perinatal transmission, so that's mother to fetus. And risk factors for HIV transmission include a high viral load. So that viral load is, again, another blood test that we get on patients, and it's an RNA level. It's an RNA level of the HIV in the blood. And so that's what I mean when I say viral load. So risk factors for HIV transmission include high viral load, certain sexual behaviors, presence of ulcerative sexually transmitted infections, lack of circumcision, as well as other host and genetic factors. So those are some risk factors for transmission of HIV. And so when I say seroconversion, what do I mean? So seroconversion refers to the development of detectable antibodies against HIV. The timing of the seroconversion following an exposure, following an infection with HIV, depends on the sensitivity of the serologic test. So this is a nice chart from our resource UpToDate. So these are some tests that we've used. The enzyme-linked immunoassay, first, second, third, and fourth generation. So currently we have the fourth generation. And as you can see, as the test gets older, it gets better. So the approximate time to positivity is a smaller window, which is good so that we can diagnose these infections closer to the time that the patient had an exposure. So for example, the first generation, it tests IgG antibodies, and the approximate time to positivity was over a month, 35 to 45 days. Now with the fourth generation, we're detecting both IgM and IgG antibodies, as well as that P24 antigen, as I mentioned in our virology part. And the approximate time to positivity is 15 to 20 days. So a much better test. And we also have the Western blot test, so that detects IgM and IgG as well. And it kind of varies, 35 to 50 or 45 to 60 days is usually approximate time to positivity. And then you have that viral load that I keep mentioning. So again, that viral load is the HIV RNA that's detected in the patient's blood. And it's a really nice sensitive test. So sensitivity cutoff of 50 copies. Approximate time to positivity is 10 to 15 days. And then when you have an ultra-sensitive viral load test, so a test that can detect 1 to 5 copies, it's even a smaller window. So approximate time to positivity is only 5 days. So we could diagnose those infections quicker and closer to the time of the exposure. So then the second stage after the viral transmission is the acute retroviral syndrome. So most persons with acute HIV infection are symptomatic, but the symptoms are pretty nonspecific and self-limited, and most acute infections are not diagnosed accurately. But so during the symptomatic acute infection, the HIV antibody may not yet be detectable, as I mentioned in the previous study with the approximate time to positivity. So it may not yet be detectable. The diagnosis can depend on the demonstration of the P24 antigen or the HIV RNA level. And again, the HIV RNA level is the viral load that I keep mentioning. So persons with acute HIV infection should be immediately linked to care for prompt initiation of treatment. So that's the current guidelines, to try to get patients on medication as soon as possible. So these are some signs and symptoms to watch out for in a patient with acute HIV infection. And again, like I mentioned, it's pretty nonspecific, so you kind of have to take the history, lab test, and these signs and symptoms all together, get a full picture. So some signs and symptoms in acute HIV infection include fever, about 75%. Of patients of frequency present with fever, fatigue, 68%, myalgias, 49%, rash, headache, pharyngitis, lymphadenopathy, arthralgia, night sweats, diarrhea. So kind of all over the place, 40 to 30%. Again, all pretty nonspecific symptoms, but if the story fits, these are things that you want to watch out for in those patients. So these are examples of non-AIDS defining conditions in early symptomatic HIV infection, and this is a nice chart from UpToDate again. So if you recall what I mentioned earlier, that there are some things that we call AIDS defining conditions, and I like I said, I will go over that at a later lecture, but these are examples of non-AIDS defining conditions, but you still see them in HIV patients. So examples of non-AIDS defining conditions are thrush, vaginal candidiasis. It's persistent, frequent, or difficult to manage. Oral hairy leukoplakia. I have some pictures later that I can show you as an example. Herpes zoster, that it includes more than one dermatome or have more episodes of herpes zoster. Peripheral neuropathy, bacillary angiomatosis, cervical dysplasia. So these are abnormal cells in the cervix. and then leading to possibly cervical carcinoma in situ, and then constitutional symptoms like systemic signs like fevers or diarrhea for more than a month, and then idiopathic thrombocytic penic purpura. So again, these are examples of non-AIDS defining conditions, but still some conditions that you might see in early symptomatic HIV patients. And so lastly, then we have chronic HIV. So we had the viral transmission, we had the acute HIV syndrome, and now we have the chronic HIV infection. So these may present with opportunistic infections. So especially when the CD4 counts are less than 200, that, like I said, meets the definition for AIDS. And opportunistic infections, again, are those like kind of AIDS defining conditions, so like PCP pneumonia, pneumocystis pneumonia. Again, I will go over that later, the later lecture. So even before progression to AIDS, patients with HIV infections may not, recurrent or severe episodes of infections do not qualify as opportunistic, such as bacterial pneumonia, herpes zoster, herpes simplex virus, or vaginal candidiasis. Other symptoms can result from chronic HIV in itself, so that includes lymphadenopathy, fever, night sweats, fatigue, weight loss, chronic diarrhea, and kind of various other oral and skin conditions. And then you should also just think about HIV or consider it in patients with unexplained cytopenias or nephropathy. So this is a picture of oral candidiasis. So you can see here, I'll kind of point it out with my mouse. So this kind of white debris that you see here in the oral cavity. So that's oral candidiasis. Again, this is non-AIDS defining conditions, but again, you can see in HIV. And this is oral hairy leukoplakia, so you can see on the tongue, again, this kind of like white debris here. And then seborrheic dermatitis, so basically it looks like it's like dry skin, and you do see this, I've seen this in many of my HIV patients. So you see it a lot, it's very common in the nasolabial folds. Another common place, and sometimes they like to test you on this, is in the eyebrows. That you actually see kind of that dry skin in the eyebrow. So those are places to watch out for. Basically, like, dry skin on the face, but those are some hot spots for where seborrheic dermatitis likes to land. So again, non-AIDS defining conditions. And so I just have two quick practice questions just to kind of get you in the mood for kind of board exam questions, and just to see if you learned anything with my lecture. So the first question, and I just want to preface this by saying, well, like a lot of our exam questions, like USMLE and board exam questions, there's a really big stem. There's a lot of words basically, and I don't want you to get thrown off by it or intimidated by it, because there are just a few key phrases that they want you to hone in on and want you to notice, and that's what's going to help you answer the question. So again, with medicine, the questions are always very long, but I don't want it to intimidate you. So I'll read this question. A 25-year-old man is evaluated for cold-like symptoms that started a week ago. He states that his symptoms include fatigue, swollen lymph nodes in the neck, and a sore throat. All of his symptoms resolved prior to him coming in for his appointment with you. He has no other symptoms. He does report that he's an IV drug user, and he does share his needles. His medical history other than that is unremarkable, and he takes no medication. On physical exam, his vital signs are normal, so normal blood pressure, heart rate, no fever, but you feel his cervical lymph nodes. No, you don't notice any other lymphadenopathy, no rash, and the other exam findings are normal. His lab studies show that he has a reactive HIV 1-2 antigen antibody combination immunoassay, and his HIV-1 RNA nucleic acid amplification testing is positive with a quantification of 11,540 copies. And like I said, the HIV-1 RNA nucleic acid amplification test is just another name for viral load. So basically his viral load is high. His viral load is over 11,000. So which of the following is the most likely diagnosis? Is it A, HIV-2 infection, B, chronic HIV-1 infection, C, acute HIV-1 infection, or D, false positive HIV-1 test. I'll give you a few seconds if you want to pause the lecture here, because when I go to the next slide, you'll have the answer. So I'll give you a few seconds here to pause and think about it. So again, just kind of hone in on those key phrases that these test question writers like to focus on. So just a few phrases. You don't need to take it that whole paragraph and swallow it whole. Just a couple phrases that they want you to focus on. Okay, so I'm going to go to the next slide, which has the answer. So if you want to stop the presentation, you can. So the answer is C, acute HIV infection. So what they wanted you to focus on is those recent kind of non-specific viral symptoms. They're most consistent with acute retroviral syndrome, although they're not diagnostic. But regardless of the symptoms, regardless that he had the cervical lymphadenopathy, the HIV testing supported the diagnosis of HIV. So we can go back to the question. So that he had the positive HIV 1-2 antigen antibody immunoassay, and his viral load was quite elevated. His viral load was greater than 11,000. And again, the viral load is the HIV-1 RNA nucleic acid amplification testing. HIV-2 infection, again, I should have said this is a person in the United States. So like I mentioned earlier, HIV-2 usually seen in parts of Africa, so not very common in the United States. So that's why that would be wrong. Again, this is not a chronic HIV infection. He's coming in with those viral symptoms, and his HIV RNA level is very high. And it wouldn't be false positive because, you know, all the lab studies say that this is a positive HIV test with the positive immunoassay and with the elevated viral load. Okay. All right, so I'm going to the second last question. So this is a 33-year-old woman evaluated after sustaining a needle puncture in clinic, and she works as a nurse in that clinic. The needle was being placed for IV antibiotics, intravenous antibiotics, and the needle had blood on it. The needle stick was from a patient who does have a history of HIV, but the patient had been taking his antivirals. He's been taking his medication. However, we don't have a recent viral load for the patient, so we don't have an HIV-1 RNA level for this patient. The nurse cleaned her wound, so she did what was right, and she has no past medical history, and she's not on any medications, and her physical exam is normal. So what would you want to do for this nurse? What is the most appropriate immediate management for this nurse? Nurse just had a needle stick from an HIV positive patient, so she had an exposure. So what would you want to do? A, would you want to give her 2 medications, tenofovir and emtricitabine? B, would you want to give her 3 medications, tenofovir, emtricitabine, and dolutegravir? Or C, would you want to determine that patient's viral load first before you do anything else? So again, I'll give you a few seconds to read the question again. Again, kind of a longer stem, a longer question, but focus on things that you need to, that are important. So I'm going to go to the next slide, which has the answer on it. So if you want to pause, please pause now. So the answer to this question is B. So you want to give this patient 3 drugs, tenofovir, emtricitabine, and dolutegravir. So this is considered a post-exposure prophylaxis. This nurse had a needle stick by a patient, so we want to give her PEP. We want to give her post-exposure prophylaxis. And like I mentioned, with PEP, there's 3 medications you want to give, tenofovir, emtricitabine, or you could give dolutegravir or valtegravir. There's a choice that's in the guidelines, but you do want to make sure to give this patient 3 medications. So like I mentioned, PrEP is 2 medications. PrEP, which is pre-exposure prophylaxis, is just tenofovir and emtricitabine. PEP, post-exposure, is 3. Tenofovir, emtricitabine, and dolutegravir or valtegravir. Okay, so I think that is the end of my lecture. This is references, so if these are references to any guidelines. If you have any questions, you can kind of go to some of these resources to clarify anything that I said. And I hope you learned something, and appreciate you listening to my lecture. Thank you so much.